This is Jacqueline from Lichen Sclerosus Support Network, where our mission is to empower people with lichen sclerosus by providing evidence-based education and support so that we can live in a world where those affected by lichen sclerosus are informed, educated, and get diagnosed early. If you find the information in your videos helpful, then please consider donating your time or money so that we can continue our LS education and support efforts. Today, we are joined by the absolutely brilliant Dr. Kalyani Marathe to talk all about pediatric vulvar lichen sclerosus. This was such an incredible conversation. I don't even know where to begin in terms of the things that I learned and the wisdom and insight that was shared. But this is such an important conversation, as a lot of times the dialogue that we see online tends to center around adults and adult cases of vulvar lichen sclerosus, and less so on children and teens with lichen sclerosus, even though we know that those populations can be affected as well. And there's lots of parents and caregivers that are really seeking this information and don't know what to do or who to see or where to go next in terms of managing the child or the teen's condition. So this is definitely a very, very important video. I hope you all give it a listen. For those of you who are unfamiliar with Dr. Kalyani Marathe, she's a pediatric dermatologist and Division Director of Dermatology at the Cincinnati Children's Hospital. She is also Associate Professor of Dermatology and Pediatrics affiliated with the University of Cincinnati. She has a monthly multidisciplinary vulvar dermatology clinic, which she runs alongside pediatric gynecologist Dr. Pennesi. Her academic interests include pediatric vulvar disease, atopic dermatitis, psoriasis, genetic skin disorders, birthmarks, hemangiomas, drug eruptions, and infections in hospitalized patients. She's an invited speaker on pediatric dermatology, both regionally and nationally. So with that, let's jump into all things lichen sclerosus in pediatric populations. Be sure to like and subscribe for more LS content. All right. Well, we are here with Dr. Marathe, and we are so excited, but also so grateful that you have joined us to talk about pediatric vulvar lichen sclerosus. It's a topic that, there aren't so many resources on. It's harder for caregivers, parents to find information and support. Mm-hmm. And if we look at kind of the support groups out there, they're usually more geared towards adults. So we're really grateful to you so that we can have more information on these pediatric cases.
I am thrilled to be here. And yes, I completely agree. This is a big gap in terms of knowledge that's available for patients and families. And it's really confusing, and it's a hard diagnosis to get or be told and not have a lot of resources to learn about it yourself at home. So I'm happy to answer as many questions as I can. I've been taking care of girls with pediatric LS for 11 years now, and it's become a big part of my practice. It's my main area of research. And I feel very strongly about taking care of girls with this condition.
Yeah, I was going to say your passion, like through the screen, I feel it. Like from the second you popped on, I was like, oh, wow, like it's incredible. So before we jump into the questions, how did you even get into this pretty niche medical space of vulvar pediatric dermatology, right? Because it's
Very
already
niche.
it's already niche to be a vulvar specialist for adults, but now we're like pediatric dermatology. Like, how did you get into this space?
It is really interesting how, mentors and life, just like luck plays such a big role in our lives. When I started at my job at Children's National in DC, that's where I was an attending for the first time. We had a pediatric gynecologist who was interested in doing a clinic, and she had noticed that there was a high proportion of Ethiopian girls that had vulvar lichen. And it just seemed very strange, right?
Right.
Because they would say, "Oh, we have siblings back home, and none of their girls have this condition. This is only the families that are here." And so she really wanted to study it more and really get to understand better. And I just jumped on the bandwagon, I guess. She was so wonderful, and I just saw how important this condition was. I saw how much it impacted the whole family
Right.
and how confusing it was for a lot of parents. And so being able to help treat it felt really meaningful. It felt like very meaningful work to me. And so I've just continued to do it. And now I've been at Cincinnati Children's for 5 years. And I have been doing this clinic with a pediatric gynecologist here, Christine Pennesi, who is
Okay.
wonderful. And so we do this clinic together, and it's just become a big part of my career.
That's
So,
fantastic. I remember the first time that I learned that there were pediatric derms out there. I was like, what? I didn't even know there were pediatric gynecologists, let alone pediatric dermatologists. So it's always surprising when you start digging through how niched down certain things can go. And I thought it was
yeah,
so impactful what you were saying about it's something that impacts the whole family, right? We always think of the person with the condition, but especially when there's caregiver roles and stuff like that, it's really interconnected and the whole family unit can be kind of involved. And so it does become, challenging. And we do have to think about more than just the person with the condition, but also, being mindful of the caregivers too, as well.
absolutely. And quality of life is such a big concern for these families. And then who is going to apply the medicine? That becomes an issue too, because sometimes we have children that have divorced parents. And so
Mm,
then dads are being asked to put this medicine on, and sometimes they don't feel comfortable as their daughters are going through puberty or, early pubertal changes. It can be really challenging. And so we have we have modified regimens. We sort of troubleshoot all these kinds of situations, but these things come up and, we have to adapt the treatment for every family. And that is a big learning for me, is this is not a one size fits all treatment that you just give them this cream and say bye.
right.
It's a much more involved thing. And so thinking through all of these things as they come up has
Yeah.
been really, it's been a great learning experience for me too.
Yeah, no, that's amazing. And we're going to kind of dive more deep into each of those layers of what you were saying as we kind of go through, the questions today. But let's start us off at the beginning. So, can you briefly explain what vulvar lichen sclerosus is and how it typically presents in pediatric cases?
Yeah. So it is an inflammatory condition of the skin. We think of it as an autoimmune condition where the immune cell, for some reason, has picked a target in the skin that is expressed especially in the genital skin. And we see this in two age groups, usually typically prepubertal girls and then postmenopausal women. So we've always thought, okay, this is related to estrogen and how much estrogen you have in your system. We're learning more and more about that, and maybe estrogen doesn't play as much of a role. But this is often diagnosed initially because people are itchy. Parents will notice that their daughter is itchy and they're just scratching, and then they take a look and maybe they see something, maybe not. Sometimes their pediatrician has not really seen this condition before, or isn't familiar with it. So we do often see a delay in diagnosis, and sometimes it takes time before people get the correct diagnosis. But I would say itch is the first thing that parents will often see. And sometimes constipation is another reason that we end up seeing patients. And they have sometimes had a whole GI workup before they come to
Right.
see me. And we know these two things are tied together,
Hmm.
but once we have to treat both things hand in
Right.
hand. And so that's usually what we first hear from families.
Hmm.
On exam, usually what we'll see is lightening of the skin, lightening or whitening of the skin of the vulva and around the anus sometimes. So that whole kind of area, we see what sort of like call a figure of eight
Hmm.
picture, where you can get this lightening of the skin, we call hypopigmentation. Sometimes we'll see little cracks in the skin, little sores in the skin. Sometimes it can look bruised or like broken blood vessels. Sometimes girls they have been diagnosed with child abuse, or the their pediatrician has been concerned about child abuse, and so they have sometimes had to go through that process. And so a lot of times these families are really fragile, understandably, because of, being bounced around the medical system by people that aren't necessarily familiar with this condition. Although I think it's getting better, and I think more and more doctors are becoming more knowledgeable about it.
Yeah, which is great. That's exactly what we
That's
want.
the
We want,
goal, right?
yeah,
That
exactly.
is the goal.
How common would you say this is in little girls? Is it something that you see often? I don't know if we have any statistics on this in the literature because, one of the challenges with children is there's not as much studies, certainly seldom RCTs, if any. So are there any statistics on that, or what do you see in your practice? And then are there any risk factors that could increase the likelihood of a diagnosis?
So we estimate that it's about 1 in 900 girls,
Okay.
but it's really difficult to say what the true incidence is
Yeah.
because the reality is that a lot of times nobody is doing a proper genital exam on
Mhm.
these children. And so I think kids that don't have symptoms, I think they get missed. So the true number is probably higher than that. I see a lot of patients with this, but that's because it's my special
Yeah.
area and I have a special clinic. But I would say pediatric dermatologists, they reach out to me a lot of times to ask for advice on these patients. So they are seeing these patients out in their practices. So there are probably more than we're capturing.
Yeah,
Um,
I definitely think that's the case. I mean, it's also the same for adults with vulvar lichen sclerosis, right? If we factor in misdiagnosis, if we factor in cultural factors that may, pose obstacles to getting a diagnosis, it's really hard to know exactly how common it is. But I do, when I talk to people in our community who are adults, a lot of them say, I got diagnosed at 25 or 30 or 40. But I think I had this as a kid because I
yeah,
remember, and then they tell me things, and I'm like, well, obviously, I can't give you like a
right.
confirmation, but that does sound like how this presents. And so there's likely a lot of cases that are getting missed. So I agree that I think the numbers would probably be higher.
Yeah, and that's the challenge, right? Is how do we capture these patients? There are studies looking at adults with it, and exactly like you said, they'll ask them, they'll say, give them questionnaires. When did
Hmm.
you like, or did you have any symptoms of this as a
Right.
child? A lot of times the people that they're asking also are postmenopausal women, and they may not remember
Mm,
whether they had, or they may just say, "Oh yeah,
for
I
sure.
remember being itchy,"
Right.
but it's really, really difficult to pinpoint. We think that family history plays a role in this. So our patients will often say, "Oh yeah, now that we have this diagnosis, we've been talking about it,
Right.
and this aunt has it, or
Yeah.
this grandma has it, and we never knew." And I think that's a major barrier for this is that the stigma associated with talking about it, really, we have to get rid of that because
Mhm.
I think the more we can talk openly about these things, the more education we can get out there, the more awareness, and the earlier I think we can diagnose a lot of people. So
Mhm.
I think that it is helpful. There's, a lot more out there. And I think there are some support groups. I know about my patients that are on they have a lot of Facebook groups.
Mhm.
They've sort of started building out a network of
Yeah.
other people that have this, and I think we're doing a better job of talking about this more, but there's still a lot of work to do.
Oh, yeah, absolutely. I remember when I was diagnosed, my GP, I'm in Canada, and she noted that, there can be some family history someone in my family may or may not have. And that was kind of all she said. And one of my first calls was actually to my sister to tell her, hey, I got this diagnosis.
Yeah,
Here are some of the signs and symptoms just for you to look out for, or for you to look out for in your daughter, just because it does slightly, you could have it. So here's some of the things to be mindful of. I also called my dad. My mother had already passed away, but I was like, did mom have this? And he was like, honestly, I don't know. She also had multiple sclerosis and was so sick that it's possible she did have it, but the multiple sclerosis symptoms were much more severe. And so that was where the neurologists were really focusing all of their
sure.
efforts. But I definitely agree, destigmatization and just speaking openly about it. It's a body part, just like any other, part of our body. If I could talk to you about my tonsils when I have strep throat, why can't I talk about, my vulva when I have a skin condition? We
Yeah,
really, at its core, it's just another part of our body in that sense. So I definitely
absolutely.
agree with the stigmatization. So in terms of risk factors, there is maybe a family history that could be one of those. Are there any other risk factors that, could increase the likelihood of a
So it
diagnosis?
can be associated with other autoimmune conditions, although I will tell you, in my practice, it's pretty uncommon for patients to have associated things. What's
Yeah.
in the literature, things like vitiligo, so we do see that
Okay.
sometimes. Thyroid involvement, those are probably the two most common things that
Right.
people will report, and that's what the studies show. Um, I would say that's not that common, but we do see it. Otherwise, we don't really know what the trigger of this is.
Mhm.
Early in my career, I worked with a group at University of Maryland, and we did a study looking at the microbiome of girls that have LS versus not. And there was a difference in their stool, and the bacteria in their stool was different, like noticeably
Right.
compared to girls that didn't have it. So I think there is some microbiome component to this that we have not
Right.
yet pinned down. But those are the main risk factors. I would say the other thing, we see constipation really commonly in this
Mhm.
population, but I think constipation broadly it has become a really common thing. We just our diets and
I was
other
going to say
environmental factors.
that's the challenge, and I think to your point about how they will often have already undergone a full GI workup is because, like, if you present to your pediatrician, your family doctor, saying my child has constipation, their first thought is probably not going to be, how's the skin?
Yeah, let me
Should we
look at
look
the
at the skin?
skin, right?
Right? We're
Yeah.
probably going to think the GI, something like that. So it makes sense, and it is quite broad, and constipation can be, a symptom of many things. So it is definitely challenging. Kind of segueing, what are some of the early warning signs of VLS that both clinicians and caregivers should look out for? And so I'm kind of thinking, constipation might be something as a caregiver that you might want to notice, especially if it's chronic, right? And it's really persisting and it's not just
Yes.
a standalone, I mean, that can happen to anybody, but if it's really chronic, really persistent, something to kind of look out for. The other thing I was thinking was, with the itch, um, maybe like fidgeting and moving in your chair, right? Because
Hmm.
I
Yeah.
think one of the challenges with pediatric cases, especially in children who don't have the capacity to speak yet, or who have some words, but they're not going to be able to just walk into your room and be like, Mommy, my left labia minora is really itchy and it feels like maybe there's a fissure near the
Yeah.
clitoral area, right? Like they're not going to be able to, exactly. And
Yeah.
so, like, if they don't have, verbal capacity, or they do, but it's quite limited, what are some things that maybe, parents and clinicians should be like, maybe this is something I should be taking note of?
Absolutely. So I think, yeah, itch is definitely a big one. And we see itch from things like vulvovaginitis in
Mm-hmm.
girls that are di outside of diapers, right? They're potty
Right.
trained, but haven't gone through puberty yet, especially early on when they're like first learning to wipe. But this itch is very persistent. It's really difficult to
Mm-hmm.
treat, and sort of our normal kind of hygiene recommendations don't
Right.
fix it. The other thing that we've been seeing more and more of is pain with urination. So a lot of
Okay.
these girls have been treated for multiple UTIs by the time they come to see us
Oh.
because they keep complaining that it burns to pee. And so then they'll also withhold their urine. They'll sometimes have accidents when they didn't used to in the past, largely because it hurts. And so if
Mm,
it hurts every time you pee, then you're going to try to wait
of
as
course.
long as possible.
Yeah.
Exactly. And so that's another thing that I think parents should be on the lookout for.
I
Some
mean,
behaviors too, like, sometimes girls will get into a position where they're sort of, rubbing their vulva on the floor.
yeah,
Sometimes that gets written like chalked up to self-stimulation,
right.
but sometimes it's more than that.
Yeah, no, absolutely. And I was thinking, man, like even as an adult, I was withholding urination because it was stinging and whatnot. So
Hurts,
yeah, I
yeah.
mean, absolutely. If they, a doctor says, your kid has a UTI and they treat with antibiotics and it's persisting, maybe we dig a little deeper uh, and investigate further. So in terms of symptoms, so we've mentioned itch. And we
Hmm.
mentioned pain with urination and constipation. Do you ever see soreness or burning of the vulva? I mean, again,
Yes.
I would assume this would have to be in a child that can verbalize that it
Yeah, that's a little
burns.
more.
Because like
Exactly.
itch, you could also infer, right? Like if you see scratch marks, you could infer that the child is itchy, or if the parent says, my child is always scratching, what's going on, you can infer itch. But burning's a little bit harder unless they can
Yeah.
say, they're of the age. But if they are of the age where they can verbalize it, is that something that can be seen in pediatric cases as well?
Absolutely. Yeah. Patients will complain of pain. Sometimes the pain is worse, is much more out of proportion to what we see on the exam,
Hmm.
even. So we definitely see that. And there's some impact on the nerves in that area. So we definitely see that some girls have a lot of pain associated. I would say the pain that we most commonly see is more associated with like open sores. So hence the like burning when you pee
Yeah.
or it hurts to poop. 'Cause a lot of times you can get little fissures and cracks right around the
Hmm.
anus where the poop comes out, and it can be really uncomfortable
Oh
to
yeah.
to
Absolutely. I mean, oh my gosh, it breaks my heart to think of a kid going through that because man, that hurts as a grown ass adult. I mean, I've been in tears on the bathroom, so I can only
yeah.
imagine.
Yeah.
Are there any ways that, in terms of presentation, clinical signs, what would differentiate, pediatric versus an adult case? Is there any differences? Or is it more or less the same?
The findings are similar. So we see that lightening of the skin that we
Hmm.
see both in adults and kids. We see we see cracks in the skin. I think we see more of that bruising in
Mm,
children.
okay,
We don't see as many blisters as we do in adults. So it's uncommon to see blisters.
great.
But things that we have kind of noticed is it seems to start sort of at the front of the vulva. So, right, where we call the anterior commissure of the labia majora, or like right under the mons, that
Hmm.
seems to be a really problematic area, and like one of maybe the first areas to be impacted.
Okay.
And we see a lot of clitoral hood or prepuce involvement in early in LS, and that is one of the most persistent and challenging to treat.
Hmm.
So that's, I think, really important. Perianal disease, I think, is about the same as you see
Yeah.
with adults, and it responds really well to topical medicines.
Hmm.
So that is luckily fairly straightforward to treat.
Right.
But those are the main things. Adults don't tend to get as much constipation as little girls do.
No, I've noticed that in the literature when I was first focusing on vulvar lichen sclerosus in adults, constipation never came up in the
Yeah,
majority of the studies. But when I looked at pediatric cases, all of a sudden I was seeing constipation everywhere. So I was
yeah,
pretty blown away by that. I guess the other thing maybe that, could differentiate is architectural changes such as fusing of the labia minora to the labia majora. And the only reason I say that is that developmentally those parts may not have fully developed yet, so it may not be as common, whereas an adult typically, all of our anatomical parts are fully developed, and so it
yes,
may be more easy to say like, hey, these used to be 3 times bigger and now they're
yeah.
gone, or something like that, whereas a child may not have developed the labia minora yet or fully, so we can't really say yet. I think that might be a challenge potentially too.
Oh, absolutely. And yeah, it's very hard to know, especially when if we see a child that has had this condition for unknown, right, for a couple of
Right.
years, it's hard to say how big should the labia minora have been,
Right.
right? Because it's very difficult to know, like, if before this condition happened, is it really? So what we do to really be able to tell from visit to visit is
Yeah.
we actually have a medical photographer
You do
with us
fantastic.
in clinic, and it does a beautiful job. And she takes these very standardized photos for us. So we look from visit to visit at photos, and we can say, oh, look, in the labia minora here are bigger than here.
Right.
Or look, it's a little sticky on this side, or oh, it's gotten
Mhm.
a little bit shorter. Um, those kinds of things are they're clues that can help us. It also is really helpful because it allows us to do the exam as quickly as possible, and the child has to be
Oh,
undressed for
yeah.
as little time as possible. I think another thing, this is maybe not what you were really asking, but I think like first time we meet a lot of families, they have a lot of apprehension and they're really nervous
Mhm.
because a lot of times the mom is thinking about, oh, I'm seeing a pediatric gynecologist and dermatologist, like, oh, they're gonna do a speculum exam or
Right,
this is
right.
gonna be really painful, or they have been had traumatic experiences themselves with their first gynecology
Yeah.
visit. But we don't do anything inside the body. We're looking from the outside. We have very standard positions that we put the girls in. We do like a butterfly leg and we do a cannonball where they pull their knees up to their chest and they we sort of walk them through that at the very beginning. And I would
Right.
say like that gives them a sort of level of comfort and everybody sort of breathes a sigh of relief. I think the other important thing for parents, is to make sure that you, one, are using the right language, right? Using the right anatomic structures, describing things by, instead of saying like, oh, private area, private part, we would rather they learn the actual terms. Sometimes people have very unique terms for their anatomy. And so, well, I've heard things like
Mhm.
pound cake. If you think about this,
Pound cake,
you know,
no.
safety wise, you think about this, right? If a child goes to their teacher and says, oh, at home, somebody keeps touching my pound cake, they're not
Mhm.
really going to know what to do with that,
Right.
right? So also arming them with all of this knowledge, it also gives them some agency over their bodies. And I think that's a place where we just have a lot of gaps, right? In being women in this world, right? We don't always feel that we have the agency and control over our own bodies. And that's something that instilling really early on is very important. Another really important thing is making sure we ask permission of the child. We explain why we're doing the exam. Who are we to be asking to do this very sensitive exam? What kind of doctors should be asking to do this
Mhm.
exam, if any? What circumstances are there where it would be appropriate, right? The parent has to be with them. Their parent or
Mhm.
guardian always needs to be with them. It needs to be the right kind of doctor. They need to be doing it for a specific reason, right?
Mhm.
And so all of these things come into play, and we have this conversation early on in our visits. And so my patients, I know they're sick of it at the end. Like I see them every 3 to 6 months, right? And so
Right.
every time I'm like, is it okay for me to take a look
They're like,
today? The
yes,
child, they're like, oh my gosh, this again. But we make a point to ask permission every
it
time
is so
of the
important.
girl and the parent so
Mhm.
that it's really clear that the power is in their hands.
Yeah.
We never force an exam also. That's very, very important. You never ever hold a child down
Yeah.
to a genital exam. If needed, we skip the exam. We say, okay, parent, you can take photos securely at home and send them to us securely through my chart or,
Right.
through our approved system. Or we build rapport. We say, okay,
Mhm.
we'll bring you back. Well, we're just
Yeah.
getting to know each other. And we'll start with some basic things and then we'll see you back. And then maybe we can do the exam next time. Or we'll bring in like child life specialists that can help
Mm.
us that are really wonderful at explaining things. And they they just lower everyone's blood pressure in the room. It's just they're wonderful people. So we do all of these things. We never ever force an exam. I think that's the other really important thing. And for parents that are going into the appointment with their child, I think that's important for them to know, right?
Right.
And I think they need to also know, like, okay, somebody should really be discussing this with the child, with me, and really making it really open and clear,
Mhm.
because that is where, you just, it's a sensitive exam.
Yeah.
And we want to be really respectful and make sure that these girls feel a sense of control over their bodies, which is what they deserve to have.
Yeah, I love that. It's very unfortunately, it's not often the stories that I'm being told. We are being told, usually the more traumatic, the exam was forced, I was held down, and then that creates, medical trauma, which creates it's just this big,
Yeah, I mean,
snowball
and there's a
effect.
body of literature that says that people don't seek care and then they have
Yes.
worse outcomes. And so we just have to be really aware of this. There's things like needle phobia.
Right.
right? Such a simple thing, right? Doing a flu shot or whatever. But patients won't go and get their vaccines if they have had a traumatic experience as a child. So we do everything possible to make this as comfortable as we can, to make it as sort of consistent as we can so that from visit to visit they
Right.
know what to expect. So
Hmm.
that there's no like
Yeah.
surprises. If we ever have to do like a swab from the outside of the skin, we always let them feel a Q-tip and feel what
Okay.
does it feel like on your hand? This
Right.
is what it's going to feel like. This is what we're going to do with it. This is where we're going to put it. I use a flashlight a lot of times. I show
Mhm.
them that beforehand. Like
Right.
this is going to be in my hand. I don't want them to be alarmed by anything,
Yeah.
right? There should be no surprises during any part of this. So I think for a parent, just knowing that this is kind of how your doctor or provider should be approaching the exam and how they're talking to the child. Because I mean, that is how we build a good relationship with the whole healthcare system, which
Absolutely.
we is really important.
Yeah. And the earlier that positive experience is given, the better. So yeah, that's absolutely fantastic. So speaking of the exam, what does diagnosis look like in children? We know that the gold standard, at least in the United States for adult cases, is biopsy, although there are certainly instances when a clinical diagnosis can be given. But I would assume we're not going to go the biopsy route as a gold standard anyway for a diagnosis of a child.
We actually don't biopsy for our
Yeah.
diagnosis. We make a
Okay.
clinical diagnosis based on appearance.
Mhm.
If we are not certain, then we will follow these girls very
Right.
closely. So sometimes patients will have loss of color. So they'll also have vitiligo
Hmm.
of the genital skin. So often the could be the vulva, could be perianal skin, but they may also be itchy. They may not have some of the other findings, right? So we're looking for things like tissue paper, thinning of the skin or wrinkling
Hmm.
of the skin. It looks kind of shiny. We're looking for those other things, like I said, bruising or little cracks or sores in the skin. Sometimes girls don't have any of those other features and
Right.
they just have the discoloration and maybe some itch. So it can be difficult to know, like, and you don't want to overdo it with treatment
Mhm.
unless you really feel pretty confident about the
Right.
diagnosis. So then we'll just follow them closely. And like I said, with the photographs really help us to tell if
Mhm.
there's been any changes from visit to visit. And the other thing that we do is we show the parent the photos so that we're not demonstrating what we're seeing on the child. We're doing it
Mm.
on a computer screen, which I
Yeah.
think gives it a level of like
Yep. I
distance
agree.
that
Yeah.
makes it more comfortable. And also then the parent we can like zoom in, we can say like
Hmm.
this is what we're
Right.
seeing.
Right.
This was last time, this is this time. You're doing a great job putting the medicine on this area, but now we need to focus on this area
Hmm.
that allows us to kind of really tailor the treatment and make sure that the parent is seeing exactly what we're seeing.
Yeah, and photographs are really such powerful tools in terms of education for both patient and provider. And also, I mean, that does sound really helpful that you can go through all of that on a screen versus on the child, because then the child's
Yeah.
potentially laying there for an extra 20 minutes as you
Yeah.
two are talking at it, at their
Yeah.
body part, basically. I would,
Yeah.
as a kid, I think that would feel very uncomfortable for me. So I love that we can then step back and get more precise with the images. But I'm just such a huge proponent of photographs when it comes to these things because it really helps give us an objective timestamp, sees
Mhm.
how, we can see how things are progressing. And I
Yeah.
always tell people like how things are progressing isn't always negative.
Yeah.
Sometimes the provider
Usually
is
we're seeing
like,
improvement,
oh my
right?
gosh, look where you were 6 months ago and
Yeah.
look at this improvement. So photographs are not always there to show worsening. They're also there
Right.
to
They're not
show
punitive, right?
improvement.
Yeah.
Yeah,
Yeah.
100%. So I love, love, love the use of photography like you're demonstrating. Do you recommend vulvar exams in young children in general, or only if a parent says like, "Hey, I've noticed something"?
So, I think a well child check is a very reasonable time to do a genital exam. It can be really quick, right? It
Okay.
doesn't have to
Right.
be a big involved thing. I think as long as you take a minute to just explain why am I doing
Right.
this or what exactly am I looking for? I don't know that it has to be done at every visit if a child is totally asymptomatic and has is having no issues.
Hmm.
But I think if things like burning with urination
Yeah.
or constipation come up, it might not be extremely clear that this is related to the vulva.
Mhm.
But those might be times where it would be appropriate to take a look. And I think if you explain it to the parent and the child, then this is what I'm looking for. You know, there are some conditions that can be related to this. And I just want to make sure that we're not missing anything.
Yeah.
And you're very respectful about the way that you do it. You know, we always have a chaperone in the room with
Yeah.
us as well, right? In our clinic, it's a little unusual because there's two physicians.
Hmm.
Sometimes we have learners or
Right.
trainees, fellows and residents. And, we always ask permission for that also and kick out anybody who the child doesn't really want in
Yeah.
there. So we always have two physicians and our photographer. So we kind of always have a built-in
Right.
chaperone. But I think it is important if you are going to do a genital exam. I think it's reasonable to pull in your nurse or medical assistant just to have somebody else in the room when you're doing that exam. Um, but yeah, I don't think it has to be done on every child, and I don't think it has to be done every visit. But usually what pediatricians are doing is doing a quick like Tanner staging, right? They're just looking for pubertal development. So they
Right.
do what I call a peek and check, where they just like look under the
Right.
underwear and then move on.
Okay. Yeah.
But you will definitely miss lichen sclerosus
Absolutely. Yeah.
with that kind of exam because you really do have to see the anatomy.
And I think you said a well child exam. Is that what you said? That might be a
Yeah.
United States thing. So is
Maybe
that
is it
like
like just like an annual
an annual? Okay,
visit?
that's what
Yeah,
I
just
was
like your
curious.
annual pediatrician visit, right?
Okay.
Where you get your like normal vaccines and sort of growth and all that stuff.
Just wanted to make sure it wasn't like
Yeah.
every time you step in the pediatric office. But I was like, I don't think so, but I've not
No, just
heard of
once
that
a year
term yet.
usually is how
Okay,
we do it
perfect.
here. Yeah.
And so, as with many conditions, the key to getting a diagnosis is speaking to the appropriate healthcare provider. And with lichen sclerosus, it's not always clear who that provider should be. So, if somebody has a child where there is potential itch or pain, difficulty with urination, what kind of a doctor should parents even be looking for? Should they just look, to a standard pediatrician, their family doctor? Um, what, are there the options there that they should be looking for?
Yeah. I think your pediatrician or family doctor is definitely a good place to start.
Right.
If you have access to a pediatric dermatologist or pediatric gynecologist, I think that that is ideal. We are working hard to get our dermatology, the whole all dermatologists
Right.
comfortable doing these exams, but I do think you're going to get a specialized level of care. I know I have patients that come see me from Florida, from like
Hmm.
far away because they don't necessarily have somebody local that they can
Right.
see. But I would say we'll give you the resource for the pediatric or our Society for Pediatric Dermatology
Hmm.
that includes the US and Canada. And so you can find a pediatric dermatologist pretty easily using that. I think that that's a good place to start.
Hmm. Yeah.
But
Okay.
pediatric gynecology would also be really helpful. Adult gynecologists have often seen this condition in older women, and so
Hmm.
they might be another place. Um, it's all experience dependent, right? If
Yeah.
they saw this during their training, or if they worked with somebody that specialized in it, then they're going to have a level of comfort with this condition. But it's really hard to know that, especially as a layperson. If you're not plugged into the medical community,
That's
it would be
it.
really hard to know that. Yeah.
Yeah. And if the pediatrician or family doctor doesn't say anything, like a lot of times what I hear is the GP or pediatrician said, "Oh, don't worry. They'll grow out of it. She's just a little itchy. She's just a little constipated. It'll be fine. Drink some, Miralax or
Drink
something."
some
And
prune juice. Yeah.
yeah, they'll kind of, it's not even that they're maybe they are, maybe they aren't deliberately dismissing, but it's just
Yeah.
not in their scope to even think about, a condition like lichen sclerosus or like
Yeah.
anything like that. So maybe, for parents advocating for their child, really saying, I think it would be
Yeah.
good to see a pediatric dermatologist. Are there any you could refer me to? Do you have any recommendations? Maybe if there's not a ped derm, maybe there's a ped gyno that we could see, but something like
Yeah.
that. And really,
not just allowing the initial "don't worry about it," because we hear that so
Yes.
many times.
The longer that I'm in practice, the more I realize that you have to listen to parents.
Hmm.
Parents, there's some reason that they are telling you like there's something
Yeah.
not quite right.
Hmm.
The more time I spend taking care of patients, the more I've realized that there's a reason usually that parents are concerned about something.
Yeah.
So, I try not to dismiss those kinds of things, but I know
Hmm.
that also practices are busy. People are in
Right.
a rush, right? There isn't always a lot of time to address every issue, but parents are the best advocates for their children. I have parents that are sometimes like, I'm so sorry that I keep asking all these questions. And I'm like, why are you
No.
sorry?
Mhm.
I'm delighted that you are advocating for your kid. Like that's what you should be doing. That's what we want.
Mhm. Right.
My own children. I mean, I'm a physician and my own pediatrician is like, you bring your kids in a lot. Like, yeah, like I do. I sure do.
Yeah.
I don't trust my own medical knowledge when it comes to my children. And I think the same for parents. I think that this is your precious child.
Hmm.
If you don't advocate for them, who is going to?
Right.
So I am fully on board. You're never wrong to ask. And, maybe you would do an extra doctor's visit in worst case scenario, and then somebody says, no, okay,
Yeah.
this is actually okay. That I think is completely fine, and nobody's ever going to fault you for that.
Right. And I would rather have that peace of mind knowing, like, all right, we did due diligence here. It really was just, something dietary that was upsetting, them and
Yeah.
leading to constipation. And there was this fix and that's it. But, doing due diligence, there's no harm in that, honestly.
Yeah, absolutely.
In terms of treatments, we know that in adult cases, first line is topical corticosteroids, usually ultra potent topical clobetasol, for instance. Is that true for pediatric cases as well?
Yes, that is still our first line treatment. Usually once or twice a day, we will do either clobetasol or one of its cousins in the
Hmm.
same class.
Yeah.
That is a very strong topical steroid.
Yeah.
I think we run into some bumps sometimes.
Mhm.
The pharmacist will say, "Oh, you're
Oh,
not
yeah.
supposed to use this on the genitals. It's going to thin the skin." Or they've seen something on social media that people are nervous about using the topical steroids. And I know that it's coming from a good place, right? They're looking out
Right.
for their kid. They want to protect them. Um, but I will say it is still the best treatment that we have, and it is effective if used.
Right.
So well, we definitely run into other situations that come up. So parents or patients will have sensory issues. So like sensory processing disorder,
Oh,
and then they can't
hmm.
tolerate having an ointment on their skin.
Yeah.
So this is a place where parents can definitely make a huge difference because we don't always know, right? We will do the exam and we'll say, well, they really haven't improved. What's been going on? How are you using the medicine? That is a good opportunity to say, you know what, they really don't like using this medicine because it
Mhm.
makes their underwear greasy. And so they
Right.
like don't want to use it. That is perfect, right? We always start with a greasy sort of ointment
Right.
formulation because it's usually the least irritating,
Hmm.
especially if you have open skin, and it tends to be the most effective in terms of
Right.
absorption.
Yeah.
But it's only effective if you use it. So
Hmm.
sometimes getting creative. We're like, okay, let's try a foam, let's try a gel, let's try
Right.
this, that, right? And so you have to play around with it to figure out what works best.
Hmm.
Parents will often be concerned about side effects. I
Right.
think, that's very appropriate. We always demonstrate like how much medicine do we want you to use.
Mhm.
I wear a fanny pack in the office.
Love it.
Uh, I always have a little tube of Vaseline. So I'll put a little blob of Vaseline and I'll say, look at how far this tiny blob of Vaseline went.
Mm.
That is how much medicine you can use for your kid's entire
Right.
vulva. I think that helps. It's some of this is education and just
Hmm.
like counseling. This is how to use it. This is where to use it. Things that we do see, sometimes parents will notice a little bit of increased hair growth on the either the mons or the labia majora.
Hmm.
I don't worry about that
Right.
as long as we're not seeing other signs of early puberty.
Okay.
But that's definitely something, if you're concerned, ask your doctor about that.
Mhm.
If sometimes we'll see stretch marks. So I would say that's probably the other kind of
Okay.
adverse effect that we see.
Right.
And that is usually from using too much medicine or the medicine in kind of the wrong places. So that's one of the reasons why we spend so much time going over like this is where to put it, this is how to
Hmm.
put it. Our nurse is amazing and spends a lot of time counseling patients about what to do, where to put the
Right.
medicine. And I think that really helps. We notice a lot more steroid side effect around the anal skin. So we've
Okay.
actually cut back on how often we have patients use it there. And that discoloration will go away,
Hmm.
but it can be confusing for people. So if you get kind of a red-brown discoloration around your anus, you might think, oh, this is active LS,
Uh,
so I need to treat it more, but really it's sort of counterproductive. So we have started just going down to like, oh, once a week around the anus. Everywhere else you do it, however frequent. Those are, I think, the main things that we will see with steroids. There's one report in the literature of a child absorbing too much of the steroid into their system, but you have to use a lot
I
to
was just
get.
gonna say, how would that have even been detected? Unless you
Yeah,
have them monitored and you're literally measuring how much medication is going on and how frequently.
so
So,
that in that particular case report, the patient was using like triple the amount that we
right,
normally
right, right.
recommend. And so that is, a question that we all often ask, how big of a tube did you get from the pharmacy? Is it a travel toothpaste
Right.
size? Is it a normal toothpaste size?
Hmm.
And how much of that is gone? So we get a kind of a sense of how much are they using and make sure they're not overusing it. But I have not seen, knock on wood, I have not had any of my patients develop like Cushing's or
Right, right, right.
steroid overload. If you have a concern about that, there's a pretty easy test that you can do. You can do a blood test, an early morning cortisol to look for whether the body is producing the appropriate amount itself. As long as you give your skin a break at some point, you're not going to develop that. So, taking weekends off, for
Right.
example, or taking a few days off during the month, that will sort of prevent those kind of side effects from happening, but it's not something we commonly see.
Are topical calcineurin inhibitors ever prescribed something like pinaclolimus or tacrolimus? That's kind of second line for folks, adult folks who don't tolerate steroids or don't want to use steroids. Are those ever given or prescribed to children?
Absolutely. Yeah, we
Okay.
use them. I would say we use them more for maintenance than we do
Okay.
for active flares. I
Hmm.
think for active flares, I still see that topical steroids work the best. But what we're finding more and more with our patients, when I first started this 10 plus years ago, we were just treating when kids had symptoms. We would treat,
Okay.
they would get better, and
Yeah.
then we would treat again if they flared again. What we are finding over time is that even if they don't complain about a flare,
Mm.
they still have some inflammation in the skin. We need to do something in
Yeah.
between. So that may mean using the steroid like 3 times a week, doing it even once a week, something
Mm.
pretty infrequent, or switching to a calcineurin inhibitor. One of the reasons that we will often do a calcineurin inhibitor is if the child is becoming more independent and wants to do the medicine themselves, but
Hmm.
we're not completely sure that they're going to know where to put it exactly,
Right.
how to apply it. Are they going to use a mirror, all that
Oh,
stuff.
I see.
So we will tell them you don't have to worry about using too much. You can
Right.
be more liberal about using the cream. And so then you can put that to the entire area without really feeling nervous about any kind of side effects. Um, there are some caveats with the calcineurin inhibitors. Sometimes the first few days that you use it, it feels weird. It feels kind of tingly or something.
Hmm.
I have vitiligo on my lips,
Okay.
and I use tacrolimus there
Ah,
sometimes, and it doesn't hurt, but it feels weird.
uh-huh.
It definitely
Yeah.
feels like a different sensation. So you
Right.
have to warn people about that. That
Right.
goes away over
Hmm.
time as you've been using it for a couple of days. But putting it in the refrigerator can help with that, and just it being cold for like the first week that you use it.
Hmm.
I think it's, we try to prepare people for these kinds of situations because you don't want to lose a child's trust by giving them something and then it feels weird or they
Hmm.
don't like it and then they're upset, right?
Right.
And then they don't want to do any of the treatments that you recommend going forward.
Mhm.
So we usually do a lot of counseling around that. I think the next level is going to be topical JAK inhibitors.
Okay.
So that's where we're headed. And I'm really excited to see some of those coming on the market and
Hmm.
being used for this because I believe that they're also going to be very effective and they may
Okay.
be a better option for maintenance treatment
Right.
going forward.
Amazing. Yeah, I'm glad you mentioned that because I am in some of these Facebook groups, more as just to witness and to hold space and to, learn from other people and learn from the community. But when parents post, I hear a lot of the doctor gave me, a topical corticosteroid. I'm using it exactly per their recommendations, and things are getting worse. The skin is all red, it's raw, it's inflamed. My kid is screaming and crying when I put it on. I don't know what to do. They go back to the doctor and say, well, that's what we have. We have clobetasol. That's what you do. And then the parent leaves frustrated and scared, thinking, how can I keep harming
Yeah,
my child? And
right.
witnessing
Inflicting
that would
pain on
be
your child is horrible.
heartbreaking, right? And being told that
Yeah.
that's your only option as a parent, when your kid is reacting like that, I think would be like heart-wrenching and awful to swallow. So I think it is nice to, even from the beginning, the, adaptability piece, right? Clobetasol is not the be all end all of steroids. There are
Right.
other types we can look
There are other
into.
types,
We can
exactly.
compound steroids. There are calcineurin inhibitors. We could
Yes,
potentially talk about, JAK inhibitor. There's all these things, but so there are things that is not just clobetasol.
absolutely. This is
Um,
not a one size fits all by any means.
right.
The other thing that brings up, though, is make sure that you have the right diagnosis.
Hmm.
Sometimes, so patients with LS can get other things
Right.
also, right?
Yes.
So you can develop a contact allergy to one of the
Hmm.
ingredients, like a preservative in one of the creams. So if the cream seems to be making it worse, it should trigger
Right.
some like, well, what's happening here?
Right.
Sometimes it's as easy as changing from clobetasol to a betamethasone or
Yeah.
something. But sometimes it's a little more complicated and you have to do things like compounding
Yeah.
or going completely outside of that entire class of medicine. Other things can make your vulva red too. So things like strep. Just like strep can affect your
Right.
throat, it can affect your it can infect your vagina and it can affect the skin of the vulva and perianal skin. So we have patients, like I have one patient that has LS and the mom messaged me and said, something is not right. This does not look like her normal flare.
Hmm.
And she securely sent me a photo and I looked at it and I was like, oh, I think this is strep. So a patient, just because you have LS doesn't mean that that's the only thing that could be going on. If something is different, I just think, parents' instincts are good. Listen to, like, advocate for your kid, right? And I always tell the people that I do a lot of talks about this condition
Hmm.
to other physicians in different specialties. And that is something I always say. I'm like, listen to the parent. If they're telling you that something doesn't seem right, something is not right.
Right.
So just keep that in mind, right?
Hmm.
Sometimes it's just concern, right? And there really is nothing else to be done differently. But sometimes there is something going on that is outside of the norm. And so you just have to broaden your picture.
Yeah, absolutely. So basically, if you have a good doctor and you trust them, speak up when things like this come up.
Yes.
Advocate, like to your point before, bring them in as often as you need, ask all the questions you need. And if you
Yes.
don't have a good doctor, or maybe they are a good doctor, they mean well, but their knowledge is just not there in
Yeah.
terms of this condition, then really advocate for a second opinion because if you're
Yes.
applying the medication and having this kind of a reaction, that's not okay. Like for
Yeah.
you or the kid, that's not okay.
Absolutely. And look, from the physician's point of view, right? So if a parent asks me for a second opinion,
Yeah,
I I am delighted, right? Because I'm
right.
like, look, either way, the outcome of this is going to be helpful, right? Either I was wrong and they get the correct treatment,
Hmm.
I get to learn something and
Yeah.
I change my practice, or it confirms what I thought, right?
Hmm.
And it helps to build sort of comfort and trust. So
Yeah.
either way, that, your physician or provider should welcome a second opinion. That's,
Hmm.
that's a good thing for us. Um, we can't be experts in everything. We don't know everything, right? We're still
Absolutely.
human. We're going to make mistakes. We're going to not know, or have a knowledge gap somewhere. So that is okay. And your provider knows that, and they should feel comfortable saying, "Okay, you're right. This is
Right.
like a little outside of my scope. Let's
Hmm.
phone a friend."
Yeah.
Um, I reach out to colleagues all the time and ask for help on patient cases that I'm struggling with, or I'm trying to figure out what to do. That's really important. This is not going to disrespect your
Right.
physician. It is, if anything, it shows that you deeply respect them, right? That you believe that they have the humility to know that they don't know everything.
That was so beautifully said. Any tips on kind of hygiene, clothing, just general maintenance from the
Yeah, yeah,
day-to-day kind of thing, advice for parents and
yeah.
caregivers?
I think a nightly bath is a great thing for prepubertal girls in particular. And what if you know the anatomy, essentially, those girls do not, their vagina's kind of wide open. And
Hmm.
so you can just like see the hymen, you can see into the vagina without a speculum, without anything. That means that urine can get in there, stool can get in
Mm,
there. Sometimes there's like a little piece of toilet paper stuck in there.
right.
So all of that causes irritation. So just literally sitting in a tub and allowing that water to clean the area gently is the best thing you can do. I'm also the parent of two children. I realize it is not always feasible to
Yeah.
do a bath every night.
Hmm.
So we also recommend a lot of like peri bottles. There's some peri bottles
Yep.
that you can just like use to squirt. You can do a bidet if you have a bidet attachment on your toilet. That's another great thing to use. Um, we like a lot of petroleum jelly
Right.
and zinc oxide, like diaper
Hmm.
paste,
Yep.
as a barrier just to protect the skin. That can be used anytime and as often as needed. We also recommend sleeping without underwear. So just letting everything kind of
Yep.
air out a little bit,
Mhm.
because we know that sweat can make things a little more itchy and uncomfortable. Um, Not sitting in a wet bathing suit. In the summertime, a lot of
Hmm.
times we see things worsen
Yeah.
because, girls are in and out of the pool. So we usually tell them like try not to sit in a wet bathing suit.
Hmm.
Try to change into like a dry set of clothing, at least for your bottom, if you are at doing pool and or beach related activities.
Thanks. Any long-term prognosis, words of hope for any caregivers and parents before we close out?
Yes, yes. A lot of girls will improve with puberty. As they go through puberty, a large proportion of girls are going to get better. We follow girls for 2 years after they start their periods to make sure that things stay
Hmm.
calm and that they're kind of in remission.
Right.
I think we're doing a better job of putting girls on maintenance if they need to be on maintenance.
Hmm.
I think there's a lot of people that are interested in this, that are working on this,
Yeah.
that are finding new treatments and ways to make a diagnosis better. Um, there's a lot of hope, I think. There's a consortium of dermatologists in the US that is a big group of people that are just interested in vulvar disease. And that you could not have said that 10 years ago,
Yeah.
right? So this is like the world is changing. We're getting much
Hmm.
better at identifying this condition, at treating it, at thinking not just about the skin, but thinking about the whole person. How is this impacting you? How is this making it hard to do gymnastics? How is it affecting your family? If, I always say is if your child is not sleeping, you are not sleeping. So what does
Yeah.
that do to like the family dynamic, right?
Yeah.
Thinking about the whole family and the health of the family. I think we're doing a better job of that now. There's obviously still work to do, but I think we're doing better. And I think girls do really well. This is a treatable condition. It does get better with treatment. And, there are people that really care about this and want to make it better. And it really is just a matter of like finding a person that's the right fit for you to help
Yeah.
take care of this.
Absolutely. Well, thank you so much for all of your wisdom. There's so much in this video that I think is going to be incredibly helpful for others to hear.
I'm so glad.
So again, thank you so
Thank you for
much.
having me. This is it's just, it's so important. And I'm so glad that you're using your voice to share this really important information and make a condition that has often made people feel really bad about
Mm,
themselves. Say like, okay, there are other people out there that are dealing with this. This is not some like thing that we have to hide anymore, right? This is something that we're allowed to talk about and we treat it just like we treat any other condition.
absolutely. And hopefully we can bring you back for part 2, where we could take a deeper dive into some of these things and maybe talk about some
Absolutely.
other pediatric vulvar skin conditions, because like you
Yeah.
said, there are others and it's all very important. Well, thank you to
Yeah.
everybody watching, and we'll catch you in the next video.